Hopefully this video isn't too traumatic. Before the patient arrives in the trauma bay, organize your team by assigning roles such as airway, IVs and medications, telemetry, a scribe, and make sure everyone knows who the team leader is. Get any necessary equipment such as airway equipment, ultrasounds, and IVs ready, brief the team, and don any necessary PPE. When the patient arrives, get the most pertinent history from EMS and immediately begin the ABCDEs of the primary assessment. Make sure not to skip any parts of each step before moving on to the next. The steps to the primary assessment are airway, breathing, circulation, disability, exposure, and then several adjunct tests that I will describe later. Airway. First, assess for patency. The best way to know if a patient has a patent airway is if they are able to speak to you. Inspect the patient for any signs that an obstruction may be present, such as broken teeth or facial trauma or burns. If necessary, secure an airway and confirm patency using capnography and by auscultating for bilateral breath sounds. C-spine is part of the airway assessment and should not be forgotten. If necessary, secure a surgical airway by median cricothyroidotomy. Breathing. Again, start with inspection. Observe symmetry of chest wall expansion. Look for any flail chest and observe for any cyanosis. Auscultate for bilateral and symmetrical breath sounds. Palpate the skin for any subcutaneous emphysema and connect the patient to a pulse ox. If they have signs and symptoms of a tension or a simple pneumothorax or hemothorax, perform needle decompression in the second intercostal space at the mid-clavicular line. In real life, you may just go straight to a chest tube. For an open hemothorax, apply three-sided dressing that allows for flow of air out, but not in. Circulation. Inspect for any sites of active bleeding, pallor or cold clammy skin, anxious appearance, or a sense of impending doom, which is a nice way of saying the patient is screaming, "I'm going to die, dear God, please don't let me die." This can be a sign of hypovolemia, traumatic brain injury, hypoxia, or ingestion of an intoxicant. You should palpate for pulses, moving peripherally to medially because weak peripheral pulses may indicate hypovolemia or a vascular injury proximal to the distal pulse. This is where you will assess heart rate and blood pressure as well. For bleeding, apply tourniquets or direct pressure. If there is no pulse, begin compressions. Tachycardia and hypotension indicate hypovolemia until proven otherwise. Start 2 large bore IVs. Give blood in a 1:1:1 ratio, meaning 1 unit of packed RBCs and 1 unit of FFP, plus 1 unit of platelets or cryoprecipitate for every 10 units of packed red blood cells. In real life, give colloids to trauma patients only if nothing else is available. On the test, give a fluid bolus. Don't be afraid to begin the massive transfusion protocol if necessary. Hypovolemic shock is classified as follows. The classes of hypovolemic shock are Class 1, which is a blood loss of up to 750 milliliters, which is about 15% of your blood volume. You will have no change in heart rate or blood pressure. Class 2, blood loss will make the patient tachycardic. Class 3 will make the patient more tachycardic, potentially above 120, and will also make the patient hypotensive. Class 4 will make the patient tachycardic, hypotensive, and the patient will begin to show signs of decreased organ perfusion, such as altered mental status or low urine output. D is for diarrhea. That's a different video. D is for disability. This means checking the Glasgow Coma score. Dead patients, blenders, and medical students studying for STEP and shelf exams all have GCS scores of 3. A GCS of 0 is impossible. Remember EVM 456. A patient that has their eyes open spontaneously, responds verbally, and obeys commands to demonstrate motor function has a GCS of 15. If the GCS is less than 8, stop and intubate here. Remember, less than 8, intubate. Also assess pupillary size, reflexes, and for decerebrate posture, as abnormalities may suggest brain herniation. If this is suspected, elevate the head of bed, hyperventilate up to 35 millimeters of mercury of CO2 for no more than 30 minutes, then hyperventilate the patient. and consider giving hypertonic saline. Do not give mannitol. It causes osmotic diuresis, which is contraindicated in trauma due to the patient's risk of hypovolemia. If the patient is stable, send them for a head CT as soon as you finish your primary assessment. Check to make sure the patient can move all extremities to make sure there is no spinal cord injury. This may lead to vasodilation, which may precipitate the need for pressors. Exposure. Complete a head-to-toe inspection of the patient with no clothing. Log roll them to assess the other side. Make sure to check areas that are commonly missed, such as the hairline, axilla, and perineum. Do a digital rectal exam to check for sphincter tone, as a loss of anal wink reflex may indicate spinal cord injury. Immediately cover and warm the patient afterward, both for privacy and because hypothermia is actually part of the triangle of death of trauma: hypothermia, metabolic acidosis, and coagulopathy. Alright, now do the adjunct exams, starting with the FAST exam, which is an ultrasound designed to show fluid, which indicates bleeding. Check the right upper quadrant, Morrison's pouch, left upper quadrant, pelvis, and pericardium. The EFAST exam adds the thorax and can be used in chest trauma. A positive FAST goes to the OR immediately. You'll also want a cervical spine X-ray to check for fractures, chest X-ray to look for soft tissue error or small pneumothoraces that were undetectable on exam, any rib fractures, hemothorax, pneumomediastinum, or an enlarged mediastinum, which would indicate aortic dissection or cardiac tamponade. You can also observe the positions of any tubes and lines on chest X-ray. Pelvic X-ray will reveal fractures such as an open book pelvic fracture. Open book pelvic fractures require the placement of a pelvic binder. Patients with pelvic fractures will usually bleed and require fluid resuscitation. Draw labs, get a CMP, and make sure to look at the bicarb, CBC, and look at the H&H, and to type and cross for transfusion purposes.
Thanks for watching. Please like, comment, share, subscribe, and hit that notification bell for more videos like this one. Remember, if you don't want to miss it, look below and click it.